system disorders. So this system in general is a little different than the others. The other organ systems that we've talked about are really, geared towards maintaining homeostasis for the individual, whereas the reproductive system is about maintaining the species across generations. And there are a number of things that go wrong, both developmentally, in other words, as the anatomy of the reproductive system forms, some things can go awry. And then there are some things that can come up along the way that can also cause disorder or disease. All right, so we're going to start with the male because there's not as many things, and then we're going to move on to the female system. All right, so congenital abnormalities of the penis. The penis forms from three discrete structures that have to sort of come together just right. So during fetal development, if those pieces don't merge and come together right, you can get a couple of different disorders that are fairly, stark. In other words, you can see them quite easily. So the two most common there are epispadias and hypospadias. So in epispadias, the urethral opening, instead of being at the distal tip, it actually opens onto the upper surface of the penis, which technically is the ventral surface, but so it comes off the top. So you're going to have urine, instead of coming out of the tip of the penis where it's supposed to come out, you'll have an extra hole there that's on the top side, more proximal. And then hypospadias, which is much, much more common than epispadias is, we have the opposite problem. The urethral opening is on the dorsal surface of the penis. And oftentimes with both of these disorders, the area of the penis distal to the urethral opening is often malformed. So these are picked up in infancy, and usually at the surgical reconstruction, they try to do it as early as possible. But because, the male infant is so small, it may have to be redone at several times along the child's life. But of these two, hypospadias is most common. Either one of these, if you see this, it warrants further explanation, or not explanation, but exploration, because usually these are associated with other congenital disorders that won't be found unless you look around on the inside as well. All right. Disorders of the testes and scrotum. A very common one that we deal with in childhood is Cryptorchidism. Now, this is where the testes are not found in the scrotum where they belong. Now, you have to understand a little bit about how the testes forms to understand how this disorder happens. So in the fetus, the testicle actually forms inside the abdomen. It begins its development in pretty much the same place that the ovary does in the female. So over the course of the last half of fetal development, that testes has to move out of the abdominal cavity, down through what we call the inguinal canal, and out through the inguinal ring, and eventually work its way all the way down into the scrotum. Now, in many children, this process doesn't complete before birth. So what you end up with is a testes that is instead of being in the scrotum, is somewhere along this path. The most extreme version is it never even made it out of the abdomen. Oftentimes you can find the testes by palpation in the inguinal canal. And if this condition doesn't resolve within the first 6 months of life, then it's a surgical correction. They basically go in and they grab the testes, they pull it down into the scrotum, and then they stitch it there so that it can't pull back. And the reason for that is a testes that is not in the scrotum, in other words, a testes that is somewhere else, is much, much more likely to develop cancer than a testes that's in the scrotum where it belongs. So, in addition, there's a fertility issue. Testes that are not in the scrotum are likely to have dramatically decreased sperm production after puberty. But the bigger concern is the increased risk for cancer. So if it fails to descend by 6 months, the urologist will descend it and then stitch it there so it can't come back. Similar to a cryptorchidism, is an ectopic testes. This is a testes that's, again, positioned somewhere outside of the scrotum, but not necessarily along this path of descent. So cryptorchidism is very common, and ectopic testes is very, very uncommon. But we have the same issue, and that is degeneration of the testes, which can result in infertility, as well as a greatly increased risk of testicular cancer. So the take-home message on both of these is a testis that isn't in the scrotum is much more likely to develop cancer as well as fertility issues. All right. Some additional disorders of the testes and scrotum. A hydrocele occurs when there's a fluid buildup in the scrotum. So we're looking at half of the scrotum. Here is the normal testes right here, but then you have this giant fluid-filled sac right here. This usually presents, again, in infancy as a swollen hemiscrotum. In other words, half of the scrotum is all swollen. And this has an interesting diagnostic test associated with it. The easiest way to tell if it is a swollen testes or a hydrocele is to actually shine a light through the scrotum. So every once in a while, you'll see a pediatrician with a light bulb shining a light through the baby's scrotum, and what they're looking for is a hydrocele. If it lights up with this kind of dull red color, then you know it's fluid-filled, because the testes is solid, so it doesn't transmit light. So usually those are congenital defects. It needs to be fixed because it can interrupt the blood supply to the testes. So when you encounter these babies that have a swollen hemiscrotum, again, the urologist is going to go in there and sort of stitch this potential space, which is called the tunica vaginalis, so that fluid can't collect there. All right. Moving later in life, so far all those things are things that are typically congenital. But a varicocele is a special kind of varicose vein. The testes is supplied by the spermatic cord that has an artery and then multiple veins that drain the testes. Also in the spermatic cord are the vas deferens, the duct that carries the sperm from the epididymis up into the urethra. But just like other veins in the body, these veins can get varicosed. Now what that means is they're dilated. This usually occurs when the valves in the veins don't work correctly. The scrotum is a dependent area. In other words, when people are sitting, blood has a tendency to pool in the lowest places, and the scrotum is one of those places. So the veins of the spermatic cord, their valves can fail, and then they get very varicose. So on physical exam, the classic description is a bag of worms, because what you feel in there is you feel all of these dilated veins, and they're sort of, tortuous and twisty, like earthworms are. Now this is sort of a big issue because it can affect fertility. Varicoceles, which is what this condition is called, it reduces the blood flow to the testes because of back pressure, and it can actually reduce spermatogenesis, or the formation of sperm. So it's one of the reasons why in an infertility workup with a couple, both the male and the female have to be examined and explored to make sure, to find out on which side the problem is. So varicoceles are a common reason for reduced sperm count because of that impaired spermatogenesis.
They wouldn't feel that.
Huh?
That's not something like...
Yes, in self-exam, they could pick it up. Yeah. This is a surgical fix. The veins, just like varicose veins, have to be revised or replaced with veins from other places so that the blood flow can return. All right. An emergency of the testes and scrotum is a torsion. So again, because the testes is suspended by this single cord called the spermatic cord, it means that it can twist on itself. And when that twisting occurs, which is what you see here, so here the testis has rotated towards your left and has kind of twisted the spermatic cord along with it. Now this twisting causes the arteries and veins to get squished together. Essentially they get sealed off, and it creates either a total or a partial obstruction to blood flow to the testes. Now the testes is not as sensitive as other areas like the brain and the heart to a reduced blood supply, but if this goes on for 12 hours, you may lose this testis, and obviously that has potential fertility ramifications. So the presentation here is usually a sudden onset hemiscrotal pain. This is intensely painful. So as the ischemia develops, the testes swells. It has a capsule that is not elastic, so that swelling together with the ischemia creates intense pain. So these can occur in both the adult male as well as the pediatric male patient. So anytime a patient has one side of the scrotum that's intensely painful, this is the thing you want to look at first, because this is the thing that you should fix as quickly as possible. Now the fix for this can be very easy. A skilled urologist can sometimes reduce the torsion, in other words, twist it back manually, in other words, without surgery. But oftentimes they'll have to go into the scrotum, untwist it. And if you've had this condition once, you're more likely to have it again. So just like the cryptorchidism, the urologist will usually put a couple of stitches in to sort of lock the testes to the scrotum so it can't twist again. Because if you've had one torsion, you're likely to have that again in your life. So they'll go ahead and fix it. All right. So those are all structural abnormalities, either ones you're born with or ones that can develop over time. Some infections that are unique to the male, prostatitis. This is an infection or inflammation of the prostate gland. The prostate gland surrounds the urethra just distal to the bladder. So you've got the bladder is sort of here, and the urethra comes off, and the prostate gland sits right here. And it's in sort of a troubling anatomic position because it literally surrounds the urethra. So anything that causes the prostate to swell has a tendency to push the urethra closed. So in prostate conditions, one of the common complaints is difficulty urinating, because a swollen prostate, essentially the urethra is being blocked or at least squeezed, so it's much harder for urine to pass through. So in terms of prostatitis, there's 4 categories. There's an acute and chronic bacterial version, there's a non-bacterial, and then there's an asymptomatic or inflammatory one. So in an acute bacterial prostatitis, it sort of is what you'd think it would be. If the prostate gland is infected by bacteria, what is it likely to do? Well, just like everything else in the body, it's going to swell and it's going to be tender. Now, those two things together are going to make it painful to urinate, and the swelling is going to make it difficult to urinate. And the acute tells us that it comes on all of a sudden. Now, this can be a secondary effect of an STD, like gonorrhea, for example, can ascend through the urethra and infect the prostate. It can be a secondary effect of a urinary tract infection. If the urine is infected, the prostate gland is very nearby, so that can be a secondary complication. And much more rarely, it can be infected by a blood-borne pathogen. So say you've had a systemic bacteremia. The prostate gland can get seeded with bacteria from that source as well. In the chronic bacterial version, the symptoms are much more subtle. So, and really they're more related to the enlargement of the prostate than actual inflammation. So we don't get a lot of pain here. We get frequency and urgency, and then some dysuria during urination. In the non-bacterial form, it looks on labs a lot like the bacterial form. So you have lots of leukocytes from the urine and from the prostatic secretions that are part of semen, but you don't, it's a negative culture. In other words, it looks like an infection, but you can't grow anything out. So that would just be a non-bacterial, probably attributable to either viral infection or potentially autoimmune disorders. So the bacterial profile here is very similar to urinary tract infections. So the single most common bug is your E. coli, the likely culprit in pyelonephritis, in cystitis, and also in prostatitis, probably because of the proximity to the anus in the urethra here. So it's an infection from the GI tract that comes up and around. But there are other potential causes, just like there are for all other infections. All right. So prostatitis. In what patients do we see this? Young men with urinary tract infections. Now we all know that UTIs are pretty uncommon in males, but they do get them. And when they do, prostatitis can be a secondary complication or a secondary infection. We also see it in men with BPH, or benign prostatic hypertrophy, which we're going to talk more about later. Anything that causes the prostate gland to be swollen increases your risk for prostatitis. And then we do see it with STDs as well. Also, catheterization. Placing a urinary catheter or a Foley catheter in a male tends to be a more traumatic affair than placing one in a female. So if you take an external, potential infection source together with a little trauma in this area, and that's another now iatrogenic reason for prostatitis. Because oftentimes, particularly in the older male, when you go to put that catheter in, it has a tendency to stop right here because the prostate gland is a little swollen. And then, you try to fish it through that little extra bit, and you might tear up the wall a little bit and then introduce infection, or at least potentially. All right, so we talked about those things already. So BPH, or benign prostatic hypertrophy, is a very, 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 very common disorder, particularly in older men. So occurs in up to 50% of men over age 65. That is a huge prevalence for any disorder. Now, what benign prostatic hypertrophy is that as men get older, particularly after age 50, the prostatic tissue has hyperplasia. In other words, more cells are formed. Now, we don't know why. There's no known reason for the BPH. We just know that it happens, and we have some ways that we can deal with it. But what occurs here is it's benign, so it's not a tumor, but the enlargement of the prostate, again, impinges on that urethra, and you get urinary symptoms from this increased prostatic tissue. So we get compression of the urethra. That causes difficulty urinating, and that causes urinary stasis. Anytime the bladder can't fully empty, you have an increased risk of urinary tract infections. And benign prostatic hypertrophy does just that. The bladder never fully empties because by the time it gets small enough, it doesn't have enough pressure to empty through that restricted urethra. There's not a predisposition to prostate cancer here, though. So it really is a benign condition. The problem is it causes a lot of symptoms, particularly for the older male. So the current thought on this is that it relates to an estrogen-testosterone imbalance. And there's a lot of research going on about how the male sexual hormones change over time. A lot of research has been done on the female side of things there, looking at menopause, looking at hormone replacement therapy and things like that. And now, the researchers are looking at the male side of things too. So it may be that testosterone replacement therapy may help to offset this benign prostatic hypertrophy problem. All right, so just the flow chart. A big prostate obstructs the urethra, which causes incomplete emptying of the bladder, and that's what gives us our problems. So we have frequency Man has to go often. Bladder distension and stasis cause cystitis and even hydronephrosis. This is where urine backs up from the bladder into the kidney and actually can cause kidney damage from the urine not being able to get out of the body past this obstruction. All right. So the classic symptoms here, hesitancy. In other words, it's hard to start the urine flowing because that prostate gland has to be kind of pushed open. Decreased flow strength. Nocturia, again, that's a common symptom when the bladder can't fully empty. And then dysuria if there is infection that's present. There are some treatment options. There are more now than when your book was made. And this is one of the conditions that you'll see heavily advertised on television. So the medications for BPH you're going to see on TV. So it's an easy way to keep up with new medicines that come out. But there are a couple of different classes here. One is like Avodart, and it actually reduces that hyperplasia, so it slows the enlargement of the prostate gland, which is the root problem. Medications like Flomax are smooth muscle relaxers, so they help to reduce the size of the prostate gland as well as making that urethra a little bigger so that urine can pass through a little bit easier. Because the urethra is a smooth muscle tube, just like an artery or the ureter is. And then we have some other medicines that also reduce the hypertrophy. There is surgery available for this, but it is usually not done unless we have an extreme case, because there's a lot of important stuff in the same area as the prostate gland. So we try to avoid surgery because there is some incidence of infertility that results, this is part of the male reproductive tract. So scarring and things like that can lead to impingement on the vas deferens. It can cause problems with sexual function. So surgery is usually avoided and medications are attempted until, nothing else can be done except surgery. All right. So into the cancers. There's a lot of cancers in this chapter. Cancer of the prostate is the most common cancer in men over age 50. Some oncologists will tell you that every male will get prostate cancer if they live long enough. And here again, we don't know why that is, but it is an important cancer, particularly in the male age 50 and over. So it's the third leading cause of death. 1 in 6 men are affected, so there again, that's a huge prevalence. Most of these are adenocarcinomas, so they're glandular, and which makes sense because the prostate gland is in fact a gland that produces an alkaline fluid. There is a whole range of aggressiveness. The more, and it follows the rules, the more undifferentiated the tumor cell is, the more aggressive it tends to be. Many of these tumors are androgen dependent, so one of the ways you can fight the tumor is to block androgens, to block testosterone production, which helps to reduce the size of the tumor, but obviously has some other side effects too. It is invasive and metastatic, 2 things you don't want to see in a cancer. Some are related to inherited mutations, but not as common as you see in like breast cancer, for example. Okay. So signs and symptoms. This one is a little bit difficult because a lot of the signs and symptoms of prostate cancer are the same as BPH, that benign prostatic hypertrophy. So really, the only way to know for sure, examination is important here. Benign prostatic hypertrophy feels one way by digital rectal exam, and prostate cancer has a different feel to it. Usually it's a very hard nodule that's kind of on the periphery of the gland. That's what's going to be concerning for cancer as opposed to BPH. Because these others are all shared in common with benign prostatic hypertrophy. There are some blood tests that are sometimes useful for the detection of prostate cancer. The PSA test, which is in the set of labs that are done very commonly in men age 50 and over. If it's positive, it's highly suggestive of prostate cancer. The problem is, if it's negative, it doesn't really tell you anything, because not all cancers of the prostate contain the PSA, or the prostate-specific antigens. So if you're concerned about cancer, you'll do an ultrasound, you'll do a biopsy, you might do a bone scan to try to detect metastases, because this tumor has a tendency to spread to bone. In terms of treating a cancer, surgery, it is a tumor that's localized, so you can go in and take it out. That's called a radical prostatectomy. Radiation is used. If it's androgen sensitive, then anti-testosterone drugs, or even orchiectomy. That is removing the testes. Obviously, that is not done very often, because now we have the anti-testosterone drugs instead. And because it is such a common cancer, lots of research is being done about prostate cancer. So probably in y'all's lifetimes, you'll see multiple new treatments and new methodologies developed. All right. The testes can also become cancerous or grow a cancer. That's testicular cancer. Again, it is usually testicular cancer is decidedly malignant. And its sort of unique niche is it's one of the few cancers that affects young, healthy men. So it's the most common solid tumor in men age 30 and under who are otherwise healthy. The number of cases is increasing. Now, that could be because we're looking for it more, or it could be that it's actually occurring more. We don't know that yet. But this is the reason that we teach young men to do testicular self-examination. So just like women are taught to examine the breast, men are taught to examine the testes, looking for this testicular cancer. Because if it's caught early, the prognosis is much, much better than if it's caught after it's already metastasized. So here's the spermatic cord. Here is what's left, I guess, of normal testes. And then this whole big mass here is all malignant tumor. So, this is pretty large. And the reason you want to teach self-examination is you can catch these tumors much, much smaller if men are taught what to look for. All right. Tumors that arise from the gonads, so both the testes and the ovaries, they can form a very unusual tumor called a teratoma. And they're the only kind of, the gonads are the only organs in the body that are capable of producing these. And you'll hear about these tumors sometimes on the news or in, on internet sites and things like that. And it's because teratomas can grow any kind of tissue or structure that the body can grow. So these are the tumors that have like teeth in them and hair in them and bone in them and stuff like that. If you haven't heard about those are teratomas, and they usually arise from the gonads. And the reason for that is, the gametes, the sperm and the ova, they can produce a whole human being. So, they have to be able to produce all the different tissue types. So tumors that come from the gonads can be particularly nasty like that and form these teratomas. All right. We're going to skip some of this stuff because I got more to cover than I have time to cover. All right, so signs and symptoms. The tumors here are usually hard, painless, and one-sided. So they're just on one testis and not the other. They can cause a kind of dull ache. Hydroceles or epididymitis, which is an infection of the epididymis, can also develop as the tumor sort of squeezes these structures out of the way. And then if it's a tumor that's secreting hormones, you can actually get gynecomastia, or the development of breast tissue in the male. All right. One of the rare tumors where biopsy is not done. Now, the reason for this is these germ cell tumors, or these gonad tumors, are so nasty that you don't want to poke them with anything, because that can actually trigger spread. It can trigger a spread of metastases. So the diagnosis is done in other ways, and then if necessary, the surgery is done. So orchiectomy, a man can maintain their fertility with just one testis, so that is often an option. And then radiation therapy and chemotherapy to try to block the spread. Now, this is also one of those conditions where a young man may bank sperm for the future, because while they may have a testis that remains, the radiation therapy and chemotherapy may render them sterile. So that's one of the options, is to bank the sperm for future fertility's sake. All right, let's do a few questions about these guys. All right, so answer the student number question if you haven't already, please. Oh, I checked my list. Then we went from not very many people to lots of people. Okay, where is everybody? Are you all not playing today?
What's the room number again?
Oh, 42, 33, 42. So you go to m.socrative. 42, 33, 42. All right. That's probably everybody. Okay, I'm going to end it. Email. All right, Cryptorchidism. What is Cryptorchidism? Get the question here in a minute. All right, jump in there, last person. All right. So the correct answer there is D. Cryptorchidism is a problem with testicular descent. And basically that means that the testis is somewhere along that path of testicular descent. So either high in the scrotum, technically that's Cryptorchidism too, or somewhere in the inguinal canal or even inside the abdomen. Usually this is a pediatric problem. Now every once in a while, you can encounter a male that hasn't had very good health care and has cryptorchidism even as an adult. But usually it's dealt with, at least in this country, as a child. All right, symptoms of prostatitis are similar to symptoms of which of those other illnesses? Good. Lots of you, almost all of you got that. That's C, urinary tract infection. So don't get confused into thinking that it's like BPH or prostate cancer. It's infection, and it looks and acts like an infection of the urinary tract, which in a way it kind of is because it's so close to the bladder. So it looks a lot like a urinary tract infection. All right. So those are some male disorders, some common ones and some concerning ones. So now we're going to do some female disorders. And you'll note that I've thrown a few slides out if you printed this off the web. So some structure abnormalities, yeah.
Can we just cross them out then?
Yes.
Okay.
Yep. Okay, so uterine displacement, also called uterine prolapse. The uterus is suspended to the back of the pelvic wall. Okay, so the uterus, here's the tubes, and it has this kind of funnel shape that comes down, and here's the cervix, and then it sort of enters into the top of the vagina. Well, what can happen, usually because of childbirth, in other words, multiparity, having had lots of children. These ligaments here that sort of hold the uterus up, they can fail, and the uterus can essentially make its way down the vagina and even out into what we call a uterine prolapse. So we've got 3 degrees of prolapse. So in, here's the normal position of the uterus. It's sort of tilted forward, and the cervix, comes down just a little bit into the top part of the vagina. In a 1st degree prolapse, it's not just the cervix that's found in the vagina, part of the uterus is too. So it has come down. In 2nd degree prolapse, the cervix is kind of at the entry of the vagina, so it's come all the way down. And then in a 3rd degree prolapse, the cervix is actually outside of the vagina, so it has come all the way through and out. Now, the treatment for this is usually surgical. The uterus will be pulled back up into position and then stitched to the back of the pelvic wall. Or if it's in an older woman, oftentimes they'll simply remove it. It'll be a hysterectomy. So this usually presents in women aged 50 or older who have had many, many children, as in 5+. And usually, it can present in lots of different ways. The 3rd degree prolapse is the most, severe form where, it presents with, my uterus is not in the right place, so to speak. Some other disorders of that same area, a rectocele and a cystocele. The vaginal wall weakens with childbirth, which kind of makes sense. You're pushing a baby that's much, much larger than the vagina through the vagina, and it has a tendency to get stretched out, and that weakens the walls. So particularly, again, with multiparity, in other words, women who have had lots of children, the wall of the vagina can become so weak that either the bladder in the front or the rectum in the back kind of bulges into where the vagina is supposed to be. So a cystocele is when the bladder is ballooning the wall of the vagina out. And in a rectocele, it's the rectum that's doing that same thing. So again, it's usually from multiparity. Surgically, if this condition is severe, in other words, it's causing massive constipation problems, massive sexual dysfunction, or massive bladder problems, then the various organs like the bladder or the rectum can be sort of stitched in a better place so that they stay out away from the vaginal wall. Okay. So those are some structural abnormalities. Okay. Some menstrual abnormalities. These are sort of general words. So these aren't really specific disorders as much as they're signs. As like symptoms, these are signs. Things that the woman can notice. So amenorrhea is the absence of menstruation. It's important to note if it's primary or secondary. Secondary amenorrhea means you had menarche, you started having menstrual cycles, but then stopped at some point. And there are lots of reasons why that can occur. Hormonal imbalance is one of those. Primary amenorrhea is a different animal entirely. This is a young woman who has never started having menstrual cycles. And primary amenorrhea deserves a workup. After about between, depending on who you ask, age 16 to age 18, if menarche, or the onset of menstruation, hasn't occurred, then you have to look for structural abnormalities, genetic abnormalities, to determine what the cause of that is. Dysmenorrhea is painful menstruation, so pain that's associated with menstruation. It's usually due to an excessive release of prostaglandins, particularly in women prior to their first delivery or prior to their first pregnancy. Dysmenorrhea is much more common. NSAIDs are very effective treatment for dysmenorrhea because it actually blocks the prostaglandins that are causing the pain in the first place. So usually begins a few days prior to menses and lasts a few days after the onset. It's often associated with uterine cramping. There again, prostaglandins make the uterus contract, so that cramping causes a little mild ischemia and also is one of the causes for the pain of dysmenorrhea. Abnormal menstrual bleeding. This is either, so there's lots of funny words here. So menorrhagia is an increase in the amount and duration of menstrual bleeding. Metorrhagia is bleeding between cycles. You can actually combine these two and have menometrorrhagia, which is lots of bleeding even in between cycles. Polymenorrhea is short cycles, and then oligomenorrhea is long cycles. So the usual cause of all of these is a hormonal imbalance. You know, the hypothalamus, the pituitary, and the ovary all sort of talk to each other and work on each other through hormones. So because you have this complex system, sometimes things can get out of whack or out of balance and can trigger anovulatory cycles, which can lead to any of these things. So there's a complex workup that goes along with abnormal menstrual bleeding that involves, you know, checking hormone levels and things like that. Endometriosis, also a very common disorder, particularly of young women. This is the presence of endometrial tissue somewhere besides the uterus. So the uterus is open to the abdominal cavity, okay? So the fallopian tubes are not like connected to the ovaries. You know, the ovary is right here. There's this space, and the egg, you know, when it's released, it crosses that space and gets into the uterine tube. Well, the lining of the uterus is called endometrium, and it's like this, and it responds to the monthly hormone cycle. You know, under the influence of estrogen at the beginning, the endometrial lining gets thick, and then in the second half of the menstrual cycle, after ovulation, progesterone makes the endometrial lining get very vascular and very glandular. And then when that corpus luteum disappears in the ovary, the progesterone and estrogen drop, and then that endometrial lining sort of comes apart and comes out. Well, in endometriosis, endometrium has gotten somewhere else. You know, so you've got like your GI tract here and your liver is up here. Well, endometriosis is where endometrial tissue is in other places besides the uterus. Now, the reason that that's a problem is in the uterus, there's an exit. You know, when the hormone levels drop and menstruation occurs, that endometrial lining that's fallen apart, it has a way out of the body. Well, in the endometrial tissue that's in the abdominal cavity, there is no way out of the body. So it still responds like it's in the uterus. In other words, it grows thick and it grows vascular, even if it's on your liver. And then at the end of that menstrual cycle, it falls apart, but then there's nowhere for it to go. So it ends up triggering lots of inflammation, lots of pain. Over time, it causes fibrosis. In other words, fibrous tissue develops in those areas where endometrial tissue has been cycling outside of the uterus, and can even lead to adhesions and things like that, where the organs of the abdominal pelvic cavity start to get like matted together from all the chronic inflammation. We don't know exactly what causes endometriosis. It certainly runs in families. So, you know, there is some suggestion of either a congenital or a genetic disposition. And the treatment is usually hormone suppression. Birth control pills in particular help to alter the cycle of endometrial growth and then falling apart or sloughing off. So that's a first-line treatment. In extreme or severe cases, surgery to remove the endometrial tissue from the areas that it doesn't belong. Now, one of the problems with that is when you remove it, you end up leaving scar tissue behind. And that scar tissue can actually make the problems in the abdominal compartment even worse. So it's sort of a catch-22. If you do nothing, you end up with scarring and fibrosis. But if you're real aggressive surgically, you're also going to end up with scarring and fibrosis. So the scarring is one of the reasons why endometriosis is associated with infertility, because it can scar the fallopian tubes, which prevents the egg from entering the uterus and from getting fertilized, and it can cause lots of abdominal problems too. So, here's the uterus. This is the only place that endometrial tissue should be. But in endometriosis, you can have it anywhere in the abdominal pelvic cavity. So fallopian tube, on the large intestine, even on the outside of the ovary, so you can have it pretty much anywhere.
And it'll be lots of locations, right? Or
Usually, yes. It's spread. There's lots of little bits of endometrium
So how do they
all around.
identify the difference in tissue in all those different areas?
You mean like how do they find it?
Yeah.
They use endoscopy. So they'll go in with a camera and they'll look, and endometrial tissue looks different than the abdominal tissue does.
They can just visualize.
Yes, they can see it. You can see it. Yeah. All right, so into some infections. Pelvic inflammatory disease is probably the worst of the infections of the female reproductive tract. This is infection of the uterus, fallopian tubes, or ovaries. And here again, it's based in the anatomy of the system. So shouldn't erase that. The uterus comes up like that out of the top of the vagina. But what that means is that there's a pathway for infection all the way up, even to the ovaries, which are over here, like that. So in pelvic inflammatory disease, the usual culprit is a vaginal infection, typically an STD like gonorrhea or chlamydia, has worked its way up through the reproductive tract and into the more sensitive areas, at least sensitive to scarring and infection. So into the uterus, over into the fallopian tubes, and then it can even get out into the abdominal pelvic cavity, into the peritoneal cavity, and cause all the symptoms of peritonitis. So normally, it's an ascending infection from the lower reproductive tract. So here's sort of what that looks like. A vaginitis, like you have in chlamydia or gonorrhea, causes, their bacterial load here, and then it works its way up around through the tube that's called salpingitis, and then it can actually get out into the abdominal cavity and cause all the symptoms of peritonitis. So one of the big problems with PID, which is what we call this, is risk for infertility and ectopic pregnancy. Scarring of the uterus and the fallopian tube means that the egg can't make its normal smooth passage into the uterus, so you can end up with ectopic pregnancy along the way, a fertilized egg that has implanted up here in the tube instead of down here in the uterus where a baby can grow. Also, scarring can be so bad of the fallopian tube that it's closed, that it's shut, equivalent to having your tubes tied, so to speak. If no egg can get to the uterus, no pregnancy can occur. And then the complications of massive bacterial infection, so peritonitis, abscesses, even septic shock. So the usual first sign here in women, STDs and vaginal infections are often not terribly symptomatic. So a lot of times the presenting symptom is pelvic pain. In other words, lower abdominal pain is how people will describe this. They'll have a fever, they'll guard, they'll have nausea and vomiting. And there's if you hang around emergency rooms that treat women, they'll talk to you about the PID shuffle. And that's because women who have PID, they walk in like this and they don't want to move their feet. And that's their guarding. Their peritoneal cavity is all inflamed, so they don't want to stretch it out. And they sort of have this shuffle that's associated with fever, pelvic pain, and usually a questionable sexual history. All right. So treatment here is aggressive antibiotic therapy. You want to stop the scarring, you want to clear the infection, and that usually requires inpatient or at least IV antibacterials. All right, so PID. You'll see patients with PID if you haven't already. And when you've seen a few, you'll start to pick up on the signs that you can see from across the room. All right, and then into the tumors of the female reproductive tract. So breast cancer, I know we've all heard lots about. So I'm not going to spend a lot of time talking about breast cancer because we all end up hearing about it in other places. But the short version is incidence increases after age 20, but most women with breast cancer are between 50 and 69, which is why mammography doesn't begin usually until a woman is between 40 and 50. Most tumors are just one side. Women who have breast cancer and are young, so between 20 and 50, are more likely to have aggressive forms. So the younger you get breast cancer, the worse it usually is. There are lots of different types because the breast has many different tissue types that make it up. Adipose tissue, glandular tissue, ductal tissue, connective tissue, lots of different things there. So many different types of cancer. The most common one, though, arises from the ductal epithelial cells. Metastasis is usually through the lymphatic system. So it doesn't spread through the blood, it spreads through the lymph, at least at first. And then once it breaches the lymph node barrier, that's when it can then spread to the lungs and brain and places like that. Some breast cancers are hormone sensitive, and that can be used in treatment. You'd rather have a breast tumor that was sensitive to estrogen or progesterone than one that isn't, because it gives you another treatment option. They can block the estrogen receptors and help to control the growth of that. All right. So some risk factors. First degree relative with the disease. There is a genetic component to some breast cancer patterns. There's been 2 breast cancer genes identified, BRCA1 and 2. Longer and higher exposure to estrogen. So what does that mean? Basically, if you're on birth control pills that have a high estrogen content and you're on them for a long time, that increases your risk for breast cancer. Now, this is what the pills in the 1960s were like. They were high estrogen, high progesterone, because we really didn't know what we were doing yet with some of these birth control pills. So there was a little bubble of increased breast cancer in women who had been on those high-dose estrogen pills for a long time. Another interesting risk factor is not having a baby or having a baby late in life is a risk factor for developing breast cancer. So, in terms of avoiding breast cancer, better to have a child early than not have a child early. I've heard it said, if you're not going to use them, they cause you trouble later. All right. The lack of exercise, smoking, high-fat diet, all those things are common, yes.
What's late in life mean?
After 35 is usually what they mean by that. Typical cancer risk factors, poor lifestyle. Radiation therapy to the chest, cancer of uterus, ovaries, or pancreas also increase incidence for breast cancer. So signs and symptoms, change on a mammogram. Okay, that one's easy. But what if you're not old enough to get mammograms, or what if you're not getting them? What can you detect? Usually the first sign that women discover is a single, small, hard, painless nodule in the breast. And all those adjectives are important there. So just one, usually small, hard, not because the ductal tissue is hard, but the other tissues are soft. And then painless, it doesn't hurt. If it's painful, it's probably an infection, not a cancer. So this thing's to look at. Later on, distortion of the breast tissue, dimpled skin, discharge. These used to be the presenting signs, but now that women do breast self-examination, we've moved from this to this as the most common presenting sign. And then, of course, mammography, which is done yearly or bi-yearly on women age 50 or older. Okay. Okay, I'm going to skip some of this. Treatment, you can either remove the tumor or remove the whole breast. That determination is usually made based on how concerned the docs are about metastases and whether you can get the whole lump, so to speak. Can you remove the whole tumor? Because this tumor spreads through the lymphatic system, oftentimes lymph nodes are removed along with the tumor or the breast. And what they're looking for there is they're trying to determine if the cancer has spread. If you find cancer in some of the lymph nodes, but not all of them, that suggests that the tumor has not gotten out of the lymphatic system. What you'd ideally like to see is no lymph node involvement at all. But oftentimes, this cancer is metastatic, so oftentimes it is found there. And then a biopsy. In this case, it's not just done to make the diagnosis. It's also used to determine the tumor sensitivity. Because there are all these different kinds of breast cancer, we want to look to see what is this particular tumor that the patient has, what is it susceptible to? Similar to what we do with antibiotics. We culture it and then we see what we can kill it with. You can do the same thing with a lot of different breast cancers. All right, so this is a carcinoma of the breast. There's the tumor there. And like all cancers, you notice that there's not like an easy-to-see line around it. Malignant tumors blend with the surrounding tissues. So it's one of the reasons that they're hard to remove. So even though this is the tumor here, there's little wisps or tendrils of tumor that come out from it. All right. Cervical cancer is some new research has shown that it's very much associated with HPV infection. So the human papilloma viruses are a family of viruses that cause hyperplasia. In other words, cells divide too fast or out of control. And HPV has been strongly associated with cervical cancer. So much so that now there's a vaccine that we talked about the other day to prevent HPV. So carcinoma of the cervix is what we're trying to detect with the Pap smear. So the current recommendations for Pap smears are by age 20 or in the year that sexual intercourse begins. So that's when you should start having them. And then how often is a thing that has changed a little. It used to be it was every year. But the current recommendation is if you're in a monogamous sexual relationship, it's every 2 or every 3 years, unless there are other problems. But again, it's going to depend on when when the gynecologist was trained. So what we're looking for is something like this. Now this is an advanced test to use in a Pap smear, but you can see all these brown cells here. What they've done is they've taken the Pap smear, which grabs a bunch of cells from the cervix. They've put it on a plate, and they've labeled the cells with what's called an immunofluorescent marker. So the green means that those are normal, healthy cells. The brown are cells that have something unusual on their cell membrane, so it stands out. Now, it used to be when they looked at Pap smears, they literally just put them under the microscope and they looked to see if the cells looked normal. But nowadays, there are these other tricks that can be used to improve the sensitivity and specificity of the Pap smear. So the concerning cells are these guys right here, which it doesn't project very well, but you can see they're sort of big and bulky. It's sort of abnormal looking. All right. So carcinoma of the cervix has this kind of progression from normal squamous epithelial cells, which is what you find lining the outside surface of the cervix, all the way to invasive carcinoma. And the Pap smear is very much geared to try to find these two spots before we get into these spots here. So we have a normal, we have a mild dysplasia. These are cells that are just a little bit abnormal. Severe, more abnormal. Malignant neoplasm. Okay, this is a cancer, but it doesn't mean that it's actually doing anything. It just is, it's malignant. Carcinoma in situ is where the tumor has started to grow, but it hasn't broken through or spread anywhere else. And then an invasive carcinoma, that's where it's broken through and is now potentially metastatic. So we want to catch these regions of the cervix, in this area, at least before this happens, before you get to number 6, because there are better treatment options. So there are a number of procedures that will remove malignant or dysplastic cells from the cervix. Probably the one that's most commonly done is called the LEEP procedure, L-E-E-P. And what's done is essentially electricity is used to destroy the abnormal cells using a kind of a electric probe. Because what we're trying to prevent here is this. So this is a whole cervix here, and this big nasty thing right here, that's all carcinoma of the cervix. So you can see that it doesn't have the sort of smooth, shiny look that it should have. Instead, it's all ulcerated and bloody and all that. So the reason we do Pap smears and we look at those things is to try to prevent this. Because what you're hoping to get is, say you got an abnormal Pap smear back, and the patient is brought in. Well, what they're looking to find is oftentimes you can see it. So if you're looking at the cervix, in a pelvic exam, here's the cervical os, and you might see a region of abnormal cells there. And with the LEEP procedure, what you can do is you can just kind of scoop that out. So you get rid of those cells that have become abnormal, and oftentimes that's enough to prevent any further dysplasia.
It's not like the cone thing.
The cone thing?
Yeah, or like they take a sample of tissue, but it's like in a cone shape.
Yes, that's the same thing. They're looking for dysplastic cells. And, all of us in medicine are sort of hoping that this HPV vaccine may really change the landscape of cervical cancer, that in a generation we may not even see it anymore. So, that would be very encouraging. So some risk factors. This is a disease that affects young women, which is probably one of the reasons why, as a society, we want so desperately to get rid of it. Because most women that are diagnosed with cervical cancer are less than 40 years of age, strongly linked to that HPV like I talked about, multiple partners over the lifespan. This isn't multiple partners at a time. This is multiple partners over the sexual lifespan. Early onset of sexual activity is a risk factor for carcinoma of the cervix. Then smoking and other STDs. Now that last one is probably because other STDs usually means that you fit this one and possibly this one too. So, all right. Then from the cervix into the uterus, this is the most, or carcinoma of the uterus is most common now in postmenopausal women. So cervical cancer is young women, and uterine cancer is usually older women. So age greater than 50. Again, that high-dose estrogen treatment that they used to use in the 1960s increases your risk for endometrial and uterine cancer. So it's a balancing act. Hormone replacement therapy, women tend to like it. They feel better. The symptoms of menopause are greatly reduced. But we have to balance the other risk factors and just try to give as much estrogen as solves the problems. Unlike they did in the 1960s where they sort of thought, well, too much estrogen is never bad. Well, now we know that that isn't the case. Too much estrogen increases your risk of breast cancer, uterine cancer, and endometrial cancer. Obesity and diabetes, also risk factors. This is not detected by the Pap smear. The Pap smear does one and only one thing. Now, it does it pretty well, but it looks at cervical cancer only. That's the only kind of cancer that it's looking for. So the diagnosis of uterine cancer is usually going to come about, by a different path. So this is carcinoma of the uterus. Kind of looks nasty there. All right. And then the last one that we're going to talk about, ovarian cancer. And we touched on this one a little in our cancer chapter because we used it as kind of an example of, how a cancer can progress. Ovarian cancer is a nasty one. And the reason for that is there's no reliable screening available. And usually, by the time it's diagnosed, it's fulminant. It's widespread, late stage, because, you know, the ovaries sit back there against the pelvic wall. They're not really next to anything. They don't have, you know, a lot of nerve supply and stuff like that. So women don't know they have an ovarian problem. And even if you were going to do a screening test, it would be hard to decide which one to do. So usually it's detected by pelvic exam, and that's where you feel a large mass, usually in the bimanual part of the exam. And again, if that's the first thing you're going to feel, well, that's a tumor that's pretty good size already, you know. And that's the other reason why it's a silent tumor, is there's no way to really examine the ovary unless, you know, it has a tumor that's already good size. So transvaginal ultrasound is useful if you're suspicious of an ovarian tumor. There are lots of different aggressivenesses. You know, the ovarian cancer is not all the same. Some risk factors, some of the same ones as breast cancer. So the BRCA1 gene, that's a breast cancer gene. Early menarche, nulliparity, or late first pregnancy, also risk factors for breast cancer and ovarian cancer. And then use of fertility drugs, which there's more and more women who have used fertility drugs for whether infertility or, let's just call it, reproductive planning. So we're seeing more women who've been exposed to these medicines. Oral contraceptives that contain progesterone are apparently somewhat protective, probably because progesterone has a tendency to shut the ovary down, whereas estrogen has a tendency to fire it up. So the progesterone, you know, that's Depo-Provera or the mini pill. Those are progesterone only, and they do have a little protective characteristics against ovarian cancer. So treatment, surgery, and chemotherapy, but there again, usually does not have a very good diagnosis or a very good prognosis because it's so advanced by the time you get there. All right. And then putting the two genders together, we have this problem that's called infertility. You know, you have a male and a female who would like to have an offspring and for whatever reason are unable to do so. So probably the most important way to think about infertility is that it's a two-part thing. You know, the male could have a problem, the female could have a problem. It could be a combo problem. In other words, it's a problem, you know, with between each other or any combination of those two. So hormonal imbalance, age, the older the parents, the increased risk of infertility, structural abnormalities, infections, chemotherapy, either currently or in the past, can lead to infertility. Workplace toxins like mercury, lead, things like that. And unfortunately, a lot of couples fall into the last category of idiopathic. They've gotten the whole workup, everything seems fine, but they don't get pregnant. You know, so there are always, you know, new options and new ideas being brought out about how to handle that, but it will probably always be a little bit of a problem. All right. And then the talk here ends with STDs, which I know you all have heard about in other sources, so I figure we don't need to talk very much about them. One of the common themes between like chlamydia and gonorrhea in particular is that the male is symptomatic, but the female is not. So the female tends to be the carrier here, or the spreader, so to speak, and it's not, and it's because they don't know they have it. So one of the reasons that STDs are so routinely checked for, even though it insults women sometimes, you know, they think that somebody thinks that they're promiscuous or something like that, but the reality is the only way that we as a society are going to get rid of these STDs is to test frequently, even, you know, when there's not obvious signs that we should be testing for them. So gonorrhea, chlamydia, syphilis we don't see very much anymore. It's the most complex of the STDs, well, short of HIV, I guess. And that's because it has these multiple stages. You know, there's an initial infection stage that looks a little bit like this. So this is a penis, and this is a chancre, which you'd think that would hurt, right? Big, nasty nodule, kind of ulcerated on the top. The weird thing about syphilis is the lesions are non-painful. Even though they look terrible, they're non-painful.
How long before you get a lesion?
Huh?
Like,
After exposure, about 3 weeks. About 3 weeks.
Are you contagious the whole time?
Yes. Syphilis is hugely contagious.
Isn't that what causes that VDR?
VDRE, I don't know what that is.
VDR?
You talking about the mental disorder? Oh, venereal disease is just another name for STDs. It's an older name for STDs.
It used to just cause like brain damage, and then people would be like,
Yes, that's
amnesia.
tertiary syphilis and quaternary syphilis affect the brain. So this will be a good way to end because we're out of time. King George, you know the madness of King George? The commonly held historical belief is it was neurosyphilis that killed him. All right, that's it, folks.